get started. As we discussed, eDose is an easy-to-use, completely web-based learning environment that facilitates understanding and mastery of drug dosage calculation skills.
Welcome to the third annual HPSN Asia Pacific Conference.
I remember about 8 years ago, I moved from Taipei Medical University here to be a dean of medical college, and I built this building. And also I equipped this building with many fantastic equipment. So our students did a very good job with a new unit, and we have a very good teaching. Also, they have very, very good outcomes. And the Medi unit also very, very effective in the clinical training, also clinical practice, especially for emergency service, also in anesthesiologist trainings. So we are really honored to host this international conference.
As you all already know, that it's increased the demand on the quality and the safety of medical practice and also medical education. And I think with the advance in technology, it is possible to simulate the medical practice in ER, in surgery, and in advanced life support, etc. And so this makes the medical simulator a great tool for training, teaching of medical professionals in a safe and controlled settings.
And he graduated from the University of Portland. Then he received the MBA from the University of Utah. He also completed the Senior Management Executive Program at the University of Michigan. And I think he's a founder and also the chairman of the board of the Medi company. Under his leadership, in 1996, they just only 5 employees. Now it's almost reached more than 200 employees. So that's a big success for him. He also enthusiastic in the medical education. So he's experienced, and also he joined the many programs attending involved in the medical education. So now he also the advisory board for the Harvard Center for the Medical Simulation in Boston. He also got a very advisory board for the nursing education at all.
When we set out in 1996, and the 5 of us, and then quickly the 10, and then 20, and whatever, and then our community of users as it grew, we set out with an ambition that I was told at the time was too bold. How can you say that you're going to set out and you, businessmen, technology people, engineers, education, how are you going to change the face of medical education? But we felt strongly then, as we feel strongly today, that all of us are involved in that revolution. We feel that at this point in time, we can never go back with what we've accomplished. This is the company, and you heard this in the film. We believe that we are the foremost provider in terms of the technology and the level of capability that we provide in education. Many of you in this room have decided with us. You've given us your trust. You've believed in us and what we've done. You've made us the foremost provider of technology for medical education. The history of simulation, simulation, we live with simulation around in our everyday life. None of us would go out to the airport today and get on an airplane if we found out, if the pilot came on and said, well, you know, the last time I trained on a simulator and I practiced emergencies was 2 or 3 years ago, but I fly a lot, so you're okay. Trust me, it'll be fine. I think that there would be a rush to the door. Nuclear plants, when they train, all other forms of our industry and our profession that affect our everyday lives train on simulation. They use simulation. Not even to speak of the military and how they train every single day. Well, prior to 1996 or the 1990s, we in medicine, we in healthcare education, we practiced. We practiced in a classroom where we learned. We practiced on clinical rounds, etc., and we practiced on each other. That's no longer acceptable. It's no longer acceptable in North America. It's no longer acceptable in Asia. It's no longer accepted anywhere in the world. Our citizens and our neighbors demand more of us. Everybody uses simulation one way or the other, and that affects our lives, and now we are effectively using it in healthcare education. I think by this time, I think we see, and we certainly in this audience believe, that we have changed the face of medical education. It's a safe, learner-centered way to teach. It offers the opportunity to do things over and over and over again safely. We understand this. It allows you, the educator, to recreate the condition of actual clinical life. It provides a means for interdisciplinary training. Simulation as a technology and as a learning mechanism in all the rest of our lives is most effective when it is present and integrated into our everyday lives. For us in healthcare, that means in the hospital setting. That means in the clinical setting. We have to develop the capability to bring it to where our healthcare professionals practice. It was founded originally as a grouping, as a gathering of fellow users. So we could come together and network and talk to each other, and literally talk to each other, but also listen to each other about what we needed. It is important that this network of user meetings continues to dialogue and continues to talk to us about what you need, what we're doing now, what we're doing right and what we're doing wrong. That's the critical part of these HPSN meetings. We are here to listen to you, but you're also here to talk to each other, to share experiences, You heard the litany of countries that are represented in this room. It really is extraordinary. I can't even imagine how many square miles we cover and from how far away.
A clinical lab in the Taipei Western General Hospital is a major teaching hospital of the National Yangming University. Okay. So we found that there are totally 30 institutes, including 29 teaching to request for their response. Finally, 18 of the 29 institutes respond. So we try to ask why there are so many institutes did not give us a response. And we found that of the 11 non-responded institutes, 3 has nobody is in charge of the training program. And 5 maybe not yet have any solid training program at all. And the last 3 are universities, affiliated medical centers. I don't know the reason. So let's look at the results. Here's the number of simulators in those institutes. We have 1 institute has 3 simulators, 8 have 2, and 9 have 1 simulator. So the total number of simulators in these 18 institutes is 28. However, we have to pay attention to that, to this data. Only 2 simulators is equipped for pediatric training. Only 2 here. And let's take a look about the time begin using simulator. I think, except the first one, Taipei Western General Hospital started their training program in 2003. All other centers, I think, have their training program after 2005. And the training settings mostly are performed in the clinical skills lab or clinical skill teaching room. 3 of the institutes may provide a mobile simulator to perform simulation program in clinical departments with the real team together. And associated equipments, all those institutes have audio-video system and defibrillators. 7 of them have fully equipped emergency cars. 14 have one-way mirror. 10 can be connected to the path of the hospital. And 9 have true real ventilators. And 7 have electronic order system. 2 have anesthesia machine and others. We have to notice that 7 of the institutes have program for communication skills and 2 for physiology and pharmacology. The teaching mode. The teaching model, I think a very popular one, especially used in the ACS, is the 3D model. It stands for describe, demonstrate, and do. So more than half of the institute use the 3D model, and 7 use 3D and RFR. That's invented by our institute. What is RFR? It's very simple. Just we take a video tab during the process, and then for reflection by the learner, feedback by the peers, or all the institute assess their learner, mostly by checklists, and some do not use checklists. And 4 of the institute use written tests. In addition, 7 of the institute using simulator in OSCE, and 1 institute using simulator in other simulation. Assessment of instructors. 17 of the 18 institutes have assessment for instructor. Mostly use the satisfaction questionnaire from learners, and 1 assessed by senior staff, and 1 use the OSCE. How about the expansion for future development? Maybe all of the 18 institutes expect to have more communication and experience sharing at regular setting among institutes, to have combination, to combine their faculty development course among institutes. Also, all of the institutes agree that we need more R&D, and we have to assess the efficiency of high-fidelity medical simulation. And 13 out of the 18 institutes, all are hospitals, hope to establish medical simulation society in the near future. Other opinions, including simulation training competition. I think this is a program in tomorrow afternoon. Case bank. We hope to share our teaching cases. And then simulation-based OSCE. I think some institutes in Taiwan use simulation-based OSCE. And combine using high-fidelity simulation with standard patient or other facilities. So the last part is discussion. I would like to discuss 2 points. Validity of our findings and the meaning of this finding. The response rate is quite low. 11 out of 29 did not respond to our questionnaire. However, as we look deeply, this institute actually, they are responders. They just represent those institutes without a formal training program. They cannot fill in the questionnaire at all. So only 3 responders. So I think the validity or the representativeness is okay. Totally, 10 of the 29 institutes which own at least one high-fidelity patient simulator do not have regular training program. So currently, probably some of the institutes like this. I think we have ongoing improvement, and I think we are going to catch up to the new realm of medical simulation. So I don't think it's not good. I think having a simulator at hand is better than no simulator at all. So totally, we have 28 simulators in this 18 institute, 2 for pediatric training. But as you take a look for the whole 49, only 3 for pediatric training. Everybody knows that babies are not small-sized adults. They are more susceptible to hurt, and healthcare giver should have specific training, especially in medical simulation. Commerce. So it's not a commerce by party. It's the commerce of us here. Have to keep on stride. So let's work hard together. Finally, I would like to thank the partners from this institute. Without their help, I cannot give a talk here. So thank you for them. Thank you for listening.
Thank you very much, Dr. Chen. I think Dr. Chen shared the strengths and weakness of the simulation education in Taiwan. Now it's a time open for discussion.
I wonder how the simulators is used in the communication skill and surgery, at least. Thank you.
It's a very difficult situation that the patient is going to die. And we have to communicate with the family during we are doing CPR. So this situation is quite usual, quite common here. We use for communications.
This is the first one in Taiwan, and I think the iSTEM improved our teaching very much, and later I will show how we try to build up our clinical competence center based on the concept of a new medical education concept, and based on our experience and our need, and how high-fidelity simulator help us to teach and to educate our resident, intern, and medical students. In my hospital, since 2004, we built up our clinical competence center. It is a very small, actually very small one. Every student see the photos and have a lot of imagination. But when they went to our center, say, teachers, would you teach me how to take photos? not for endotracheal tube. This is a pity. We have built a lot of simulators. The first one, the human-like, or part of human-like, different models. And we also set up our simulated ICU here. I think maybe some of you will visit my center in days later. I think you must visit ours at first, then go to Trip Chance. Trip Chance is much better, but small but lovely, and we can do many things here. And we just bought a lot of different. We like the Penta AWS. It's an easy way to insert a tracheal tube, and under the infection risk, you can just have quite a distance to prevent not infected during intubation. And we also have different kind of machines. The different model provide us integrate the real patient, the standardized patient, and the models, and we can teach PE by the human demonstration. But if they want to get the injection, don't inject my shoulder. Please inject on the model, on the simulators. Also for tennis elbow, and also for when they try to aspirate joint fluid from swollen joint. By simulator, that's better. The satisfaction rate is excellent. So if you are pushed by your boss about how to raise the satisfaction rate, just use simulator and teach them some procedure under your monitor. I think it is a good idea. And we also have a more advanced one. This is a sono simulator. Because we have a mannequin of sono simulator, so we let students perform sono on real patient or real men or their classmate to transform the idea of 3D into the slicing image, and then use the simulator to teach them the pathologic condition, because it's very hard to collect acute cholecystitis, hepatoma rupture, acute pancreatitis in the afternoon, but without at cost of patient's treatment delay. So we use a simulator to teach a pathologic condition, use the real man to integrate the idea and transform the 3D into 2D slicing view. The satisfaction rate also very good, because they really learn something. Then we set the OSCE for them to test them, and we set up a checklist, checklist, and to perform that. It's a usual rheumatologic OSCE condition. We use a standardized patient and perform PE to test the human communication skill. And when we must have an injection, we use model. So integrate real man and simulator might be the best way. And this picture is Also another, because in Taiwan we have a lot of patients. Lots of patients means some frequently we have to answer some question especially from surgeon. They will ask me, why don't you just perform procedures on patient? Why you have to use this kind of a model looks somewhat strange and have to use that. I think this picture, for me, I'm a rheumatologist, so the injection skill for me, like a tennis elbow, is important. But even I just stand beside my student. After the needle enter the skin, then no one knows where is the needle. We don't know where the needle tip is. Even you just stand beside him or her. It's impossible because the tip is just where it is. I don't know. I don't have like the Superman has the X-ray eye, and then okay, it's a correct position. So even you just stand or sit beside them, you don't have anything to check. We try to approach our education purpose, so we need different kind of simulators. In the past, we learn on patient, but if everything learn on patient is best, why don't pilots just learn on us? But actually, they need a simulator, and both of us physicians and pilots, both of also handle a lot of life. So if they need a simulator, and they need a simulator every year enough hour, not only on real flight, also on simulator. So I think it's a very straightforward way to know why we don't use a simulator on our daily education. As pilots, could they educate new pilots without simulator? If the answer is no, then we, physicians and the medical professions, we need simulator. So maybe better ways do cardiac cath, even this highly technical demanded procedure. They could try it on more practical way by simple simulator. Then the different way, like we have a different kind of simulator now, and then go to real patient. Like even the endoscopic operation, or even more complicated one, the cabbage, they can perform on that. Why we need this? That's another point is the simulator can record the process. It's a very difficult to record process during the real procedure because you must focus on patient. So the simulator, they record the whole process is very helpful for us because later we can under the monitor and then have the feedback by video playback. And it's a poisoned drink. In 2005, they have a very terrible crime. He gave poisoned drink to store, and the first one patient with a bottle of a drink, just like this. We call it a 毒蛮牛. The ox on the bottle. They usually to like the coffee to improve our energy and to then become energetic. So many one just open it and drink it and forget to see the bottle with label. It is poison. That's a terrible thing. So the first one was sent to other hospital and he died. And the second one and the third one were brought to my hospital in the ER, and our ER doctor are very clever. They quickly found it's a strange metabolic acidosis, so they change the way and contact with toxicologist and find out it's a cyanide toxification and save the others' lives. But if we can just learn by experience, how could our hospital keep this performance next time? The cyanide toxification is not everyday's life. So it's very difficult to learn by this. Finally, they cause them because we found it's a poison crime. So they use the video playback to find out this one and got some. Finally, it's life sentenced to life prison. So we put the poison drinking scenario into our high-fidelity simulator, and then our students can practice again and again, and yearly with cyanide intoxication without any cost of their wrong decision making. So I think it's the things beyond experience. The simulator can easily prove we can learn things without a cost or not limited by experience only. Speak nothing and do nothing, then why don't they just put a model over there to replace me? But I think the influence, the PBL it performed well. So I try to learn something, but I found it very difficult. But in Harvard, I really learned something. This GIBER program, the simulator program in Harvard Medical School, their simulator is a more basic one at that time, about 6 years ago. But they have an electronic blackboard controlled by the tutor in the backside, and he can control what to give the information or pictures to this. And there's a clinical case challenge scenario by 2 tutors, one with the students and one control the mannequin. And their target group is a medical student, grade 2, just very young, very young. And but their focus when we join that, we think, wow, it's for R2, it might be better, not for medical student grade 2. They focus on clinical reasoning and differential diagnosis. But they use it. They use a mannequin. Just a student asks where it hurts, and it's recorded by the video recorder.
Chest is hurting. I can't breathe. Do something, please. It's hurting. Please. I can't breathe.
Don't worry.
What's wrong with me?
So, put on the C-spine.
You've got a bit quiet, man. You're still blinking. It's okay.
How are you? How are you?
It's hurting. Don't hit me.
Do you have any pain?
He's no radial pulse.
No pulse.
His radial pulse is very weak.
Okay.
Start CPR. CPR.
Right, CPR. Give me a needle decompression.
Okay, needle decompression done?
Needle decompression on the right side.
What do you think is the result of the needle decompression?
Nothing, it's not worked. Chest isn't moving.
Is the chest moving?
Maybe the blood pressure is good enough for a CPR.
No case.
Let's check whether he's breathing.
The one-sided.
2-minute cycle, so.
Is the patient breathing?
Not yet. Oh, he's blinking.
He's got his eyes.
Looks like there's a response to the needle decompression. He has a pulse.
Okay?
Here's a carotid pulse.
Okay.
No case.
His problem is his BP is still low.
Right, fluids up.
Okay, good. Fluids
Tip,
on.
tip the,
Fluids up. Okay,
Yeah,
fluids
yeah,
went down. Okay, assume that it's tipped up. Okay, fine.
He's making some respiratory effort.
I'll get some bloods for group and cross match.
Okay, blood grouping set.
Okay.
Group and cross match 5 units.
Okay, great.
We'll be ready in 15 minutes.
Blood, fluids are on flow.
Okay.
Would somebody like to look at his CBP?
Not
Not able to hear the properly at all.
It's dull,
Yes.
muffled, can't hear much.
Yes, yeah. Okay, fine.
That's very good.
Okay, thank you. Assume, done. Thank you very much.
Very good. Thank you.
Okay, let's give them a hand. Went through it very rapidly, and that was because our objective was not to resuscitate the patient. But I'm very happy to say that you picked up the problems very quickly and very nicely. We did run the same thing in Miami in March, where I think they had some difficulty picking up the cardiac tamponade. And that happens in real life as well. Now he's basically had a chest injury and he's got a double problem, right? Do you think that the scenario, the way it ran, reflected this fact of the tension pneumothorax as well as the cardiac tamponade? The fact that you had now, of course, I noticed that you went off to see the pulse and those details without exposing the chest, which is probably the reason why the tension pneumothorax was not picked up immediately. But once you relieve the tension pneumothorax and you rightly pointed out that the BP is low and you gave fluids and it was not improving, you could see that the CVP was still high, and then you guessed that it might be cardiac tamponade, and when you relieve the cardiac tamponade, the patient has come back to normal. So am I right in saying that this is sort of reflects reality to some extent? Okay? We are just saying that he's had an injury, he's had a chest trauma, clinically he's got a cardiac tamponade as well as a pneumothorax. So it could be even
the cause we don't know.
we don't know the cause of it. The idea is to treat the situation and then to investigate the cause. So we are not going into the diagnosis of the patient here. We're just going into the conditions that he came with and relieving those conditions. Okay?
Thank you.
Any other questions? Okay, if there are no other questions, then what I would like to show you. Now this is basically what we mean by complex scenarios. I do not know whether this term has been coined by anybody before, but when we were working out and when we were giving patients multiple problems, we decided to call it programming of complex scenarios. Right? So a complex scenario is basically one where the patient has got multiple clinical problems at the same time. Now when you want to program complex scenarios, you can do it in one of two ways. One way is to write a single script, a program, which encompasses both, in this case, cardiac tamponade as well as tension pneumothorax. Okay? The other way, of course, is what we have done over here, is to write two separate scripts.
Usually, anesthesia non-technical skill system has a category and element. So, as shown slide in, it's very convenient for us to use in clinical practice. Anesthesia non-technical skill developed at the University of Aberdeen in England. So now many Japanese and many anesthetists are using this system worldwide. So our simulation center making training for junior and senior resident, and also 3-day course, so from morning to evening for 3 days. And also we are making training for anesthesia, senior and junior anesthetists, and also the medical students, nurses. Why we are using HPS? HPS has many advantages as compared to other high-fidelity simulators. As shown in slide, especially pulmonary function pulmonary function is superior to other ECF and similar. For example, HPS has a spontaneous breathing with inspiratory and expiratory flow. This system is very useful for the training of respiratory care and the use of respirator. And also, HPS responds many kinds of drug. So, what is the advantage to use high-fidelity simulator in anesthesia training? As shown in slide, there is no risk to patient, and error can be allowed to occur. The same scenario and the situation can be presented repeatedly and rarely. And the trainee can actually learn how to use complex devices. And also the recording and reply by using videography are easy. And also we can use for the training of anesthesia non-technical skill. And we can use it in the training and the management of event rarely encountered in practice.
I prepare all things and I will start with the induction. And I will give the patient fentanyl 200 microgram and 120 milligram Zarotide, and propofol for about 200 milligram, and the rocuronium 120 milligram.
In 30 seconds to 60 seconds, when I'm sure that muscle resistance is full, I will do the intubation.
Well, older students mean the senior students?
How you maintain them while so many students are...
No, we have about 20 of them per session, not more than 20. So the first 10 would be handling the patients, the other 10 will be looking and maybe passing comments. Then we rotate. So we have about 2-hour session each time.
So are you allowed the student practice?
Yes, we do. So we take precaution. Yes, not every class, but depends on...
After the class?
Not after the class, if there is no one to, yes. A simulation? At the moment, not that I can think of, because we've only just started it in 2009, fully utilizing it in 2009. So far, the staffs have not made any complaints, except for the scheme. You know. Some other technical problems, at the moment, no. Maybe we have not exhausted all the other kind of things that we use, because the nursing curriculum programs we've only just purchased a few months back. So that is still at its infancy stage. Yes?
You mean you apply HPS to all nursing courses?
All nursing courses subject to what specific procedures that we like to perform that will require, that is most well done if it is on a patient simulator.
They are foreigner or in Taiwanese. If all are Taiwanese, we can we use it? Maybe I.
正在开始的一个护理人员的一个教学哈，那大家一直很想在这边，就是等一下想看我们玩嘛，对不对？可以，等一下我们可以 demo 给大家看哈。但是因为这个不用很多时间，我们还是很想听听说在场的，我想说都是护理的老师来告诉我们说，我们还有哪个地方还做得不好，还是说可以给我们一点建议这样子，或者说您个人的经验这样子。
怎么推
怎么推给所有的护理人员
？OK， 其实因为我本身是一个专科护理师，刚刚你有看到有另外一位是黄君厚护理师，我们其实有把我们的工作分门别类，因为他本身是在 ICU， 所以 ICU 的领域都是专门交给他，而至于其他的，也就是所谓的病房的护理人员，也许就交给我。那至于目前为止，因为我们都知道 HPSN 很多的 paper 几乎都是用在 ICU 或是急诊一些重症单位。所以，对于一些病房的护理人员来使用这个东西，有点刚开始会觉得有点大材小用，因为病房并没有什么 EKG monitor， 不会直接架上去，你会马上看到，都一定要把机器推过去之后才会看得到。所以，的确刚开始会做的有点困难。那但是因为现在好险的是，因为我本身是在 PGY 病房，一般医学内科病房，所以对于一般医学内科病房的护理人员，他必须要照顾的病人就更多的种类，所以他们在推向这件事情的话，有护理长很支持，督导很支持，所以在推的时候，其实护理人员他们也知道，他们的年资很浅，他们要做这些东西的时候，或照顾类似这样子的病人的时候，会压力很大，所以这些学妹来说，其实要号召他们其实是很容易的。那但是你会看到，为什么我做了那么久才就 include 了8个护理人员呢？这是很有趣的问题，这就是牵涉到了我的 limitation 的部分。因为其实现在在东部地区的护理人员其实人力是短缺的，所以我们不可能是要求他们每天下班就是约好时间就要马上过来。我们必须希望，因为我们想要看到的是在他们精力最旺盛、脑袋最清楚的时候看到的结果，所以我们会给他们时间，让他们来学习。所以其实，在推广这件事情的话，有很多的一些主管支持，那我们也愿意耗费我们的时间。那有一些所谓的金钱，不是金钱，有一些额外的小小的福利提供给这样的护理人员，他们就很愿意，因为毕竟学到的东西，他们可以应用在临床上，他们不用担心说做不好被医生骂或什么的，他们会有得到成就感。
The main goal of this case. Thank you. Thank you for your comment.
So, happy hour is coming. You can, I think it will impress our demonstration. Now I will talk about multiple trauma after compressed crash injury in the earthquake. So we know there are many disasters in the world: tsunami, war, air disaster, multiple traffic accident, and the terrorist attack. So this disaster will kill many people in recent. And we know earthquake is from the plate slide over, and it will occur mostly at the boundary where the plate meet. And this earthquake caused many disasters, more popular. And Taiwan, we know their famous earthquake is 9/21 in Middle Taiwan. In 1999, 9/21, this earthquake killed more than 2,000 people. It's the famous GG earthquake. It reached rate degree 7.3. Next. So because our hospital is a military hospital, so our hospital has established the medical disaster rescue team. When there is some need help, our rescue team will reach quickly from hospital to the scene. Now, Dr. Xu could show me what is primer survey. The primer survey, Dr. What is primer survey? A is airway management and C-spine protection.
I'm coming.
It's hurt.
Hi, soldier. How are you?
Oh, it's quite hurt.
Can you hear me?
Oh, painful. Help me do something quickly.
Okay. Don't worry. I'm Dr. Xi. This is Miss Tai. This is Miss Lee. We are going to help you.
Quickly. It's so painful.
What happened to you?
Doctor, quickly. Can you give me something? Morphine or something?
Okay, we do ABC. I will check his breathing.
Oh, it's so painful. I cannot breathe.
Their chest wall is clear.
Doctor, quickly, quickly.
Okay, don't worry, don't worry. This position is strong and rapid. How about the heart rate is more than 100? Okay. Then, how about its saturation? 98. Okay. Then exposure. Ecchymosis or the leg frontal region. Okay. Can you move your leg?
No, it's harder to move my left leg or my right leg.
Oh, there is a jam open wound over your right leg. Oh, so I realize.
Oh, so painful.
Why you are so pain? Oh, I will give you some drug for your pain. Can you move your left leg?
I see it's fine.
Okay. Can you move your left hand?
Yes, quickly.
Quickly. Please clean his wound. And give a gauze compression elastic bandage. I will check the dorsal PD position. Left side is good. I can feel the position on the right side. Check it again. Right side dorsal PD is absent, so I will give him a trace.
It's so painful. Can you be gently?
Okay, I will traction to a traction.
Then, the students who got a better grade during the exposure to the secondary hospital got a lower grade, that is 84.22. Meaning to say, even though they have this decrease in the grade during the exposure to the tertiary hospital, still, the students assigned or exposed to the simulation got a better grade than those who were not exposed to clinical simulation. Okay, another secondary hospital. Now, Perpetual Socorro Hospital is located in San Pablo, Manila. Okay, now it was a maternity clinic before and started to accept medical surgical patients in the early 2000s. Now, the mean grade of the students who will be exposed to clinical simulation is 84.04, and those who will not be exposed to simulation is 86.17. Okay? Then, when this group of students are assigned in the same tertiary hospital, the one with clinical simulation exposure got a better grade, that is 85.81, as compared to the students who have no patient simulation exposure. Another hospital, so we have got Andres Bonifacio General Hospital located in Tondo, Manila. Now, this one also caters to the class D and E patients. The students of Group A got 83.42, while Group B got 86.54. Now, during their exposure to the Armed Forces of the Philippines, this is a tertiary hospital with 300 bed 50 capacity. It caters to military personnel.
Nobody cared the situation. This might happen for very important parameters they forgot. With 3 or 4 people in the room, they are shouting, oh, give me something, give me another thing. So others are, floor in the room. Finally, the vanilla is on. Find the right button to push the wrong button, push the right button. So by the video, we prepare video to do a debriefing. The trainee, our residents and the nurse anesthetists, they will get a better understanding what need to do and they don't, and what should be looked at, they don't. So they get a more strong impact as they learn something.
You need to have dual thrust. What you need to do is make sure that the airway, the upper airway is patterned to let out the oxygen. It's a bit like working with children and animals. It doesn't ever work the way you want. And we practice this in our simulator in Hong Kong. I personally wouldn't remove the pillow, but that's personal preference. I think moving his head back and extending his neck is an important thing to do. So probably put something under the shoulders. But I think your patients here, opposed to my patients, are a lot skinnier. I've got a lot of big patients. Okay, looks like he's surviving, better than my attempt. He's getting better. The fresh gas flow, because of the higher pressure, you need high pressure through the cannula. You can't bag through the cannula. One of the recommendations that I had, I worked in an ENT hospital for a year, and one of the consultants there, obviously the lungs do deflate initially, and you need to re-inflate them. But if you're worried that the chest is not decreasing, so you're not having any expiration, you can just insufflate some oxygen, which sometimes buys you enough time to have the surgeon arrive and hopefully put in a surgical airway for you, unless you're still doing it yourself. This one we all got pressure sometimes. Okay, I think we'll leave it there. I think you did very well. It deserves a round of applause, actually. You did far better than I did.
You can just walk in now and then see how well you can manage the patient from here. So that allows them to not feel bad. Okay, that's very important. You don't want a student to jump from the 4th floor after the scenario. It's the last thing you would want. So, some of them think that they are video shot and their boss is going to know. No, it's not. It's for teaching purposes. Yeah. So it's important to pause, get your point across, involve the audience if the participating audience want to comment more, help them to regroup, resort and start back from what they are. We talked about trial runs, we talked about paper scripting, we talked about dry runs, offlines, and rehearsing with the mannequin and something about timing it. Because in your curriculum, there is going to be only a brief moment in time where we come to the skill center. So if you as a faculty has more things to do, or they as students have of course other things to do, you cannot finish if you don't have set structured guidelines to do things. To do this, you can do with the log function, but while you're playing a scenario, there is something called on the fly. Like, though you might have pre-programmed ones, you should be ready to be flexible. Flexibility is to acknowledge people who are doing good things and also to tell them that this is wrong, this is unsafe. You can never anesthetize a patient, you can kill them in 20 seconds doing this. So if you look at a few exam boards like the UK, you might have done well in all aspects of your exams, but it's the last day, the last 2 minutes of the viva, if you're saying, instead of sedating, I'll probably give him a relaxant, he's moving too much. So they know you are unsafe. They will make sure you don't cross there. So there must be moments in your simulation session where you should be able to do things on the fly, which is programming as you do it.
Basically, all of you know that you can change parameters in 2 ways. One way is to script it into the scenario so that it automatically takes place. The other thing is to, even when the scenario is going on, to use the tabs that are there either the cardiovascular, respiratory, whatever tab is there, and you change the parameter through the tab. Whatever changes you make through the tab will override whatever you have written into the scenario. So that's what he's meaning by saying doing on-the-fly changes.
Yeah, and you could see in many places while you are running this, the student would defibrillate when the blood pressure is normal, would be doing a CPR and there is a palpable pulse. Well, it's nice, they can do it the ACLS trained way, but it's inappropriate. So you need to tell them that, look, you did this. I had to crash the patient after that. This was unacceptable. Yeah, it may not be in your curriculum goals and things, but this is unethical if the student is doing certain things which are not expected. So intubation without a proper sequence of drugs, like you would have given one midazolam, they would see the saturation is 90. First thing they will do is intubate conscious groaning patient with just a saturation of 90. Well, in an ICU scenario, you just watch it. In a ward scenario, you will really be worried about it, and then you sort it out, but we may not intubate.
Also, in the field, they provide the users with the guide, so we can follow the guide to use the simulator. Also, but I have a question. The question is that if a brand new simulator is just show up in your hospital, who should take care of that? Who should use this? The dean of the medicine. You involve the dean of medicine, he should take care of that. Or the emergency department, because it's designed for a critical condition. They should take charge of that. Is that a good answer? Or the perfect answer? I think no. And the budget does buy you the simulator and the lab, so you can build out the environment and build an expensive simulator, but they didn't promise you a good faculty. So I want to continue this topic. Where's your faculty? Where's the faculty? So you have to think about how to set up the software. Sorry about that. And this is today's outline. First of all, I will explain the Taiwan medical training background briefly. And point two, next, I will focus on the key points of how to maintain a good and effective team to teach the simulation education. And in the third part, the tutor's idea were presented by the videotape during the presentation. I will introduce the 2G simulation steps in the final. 7% of them study in the medical school in western part of Taiwan. You can see almost 97%. And I'm so honored to introduce, okay, here we are. Today is the celebration, the ceremony of the Fudan University, 85th anniversary of this university. So I want to congratulate you. And I'm so honored to be here to give you a speech. And my map, now that's totally different. Now we have PBL, OSCE for the basic science, and we prepare the preconditioning solution, including the clinical skill test and the standardized patient test, and also surgical simulation program for the preconditioning before they came to clinical practice. Once they became the resident, they daily practice. They learn by the practice, clinical practice every day. And finally, they can become the specialist. So, through this teaching methodology, they will pass the first step, also the second step of the medical board. After they study in the medical school for 7 years, finally they become the resident and they practice daily. After a few years, they will pass the subspecialty exam and become the specialist.
Okay, and after patient have the C-section, the sign and symptom we need to monitor. If the patient after deliver the baby, what kind of symptom and sign we need to monitor.
After patient have sleep session, usually we want to monitor what kind of vital sign or symptom.
你现在觉得怎么样？你子宫收缩会不舒服吗？我可不可以看一下你的那个伤口？
She is asked her how is her feeling now and how is her contraction with her uterus.
然后就要围连。然后对，然后就是看伤口，然后我摸一下你的子宫收缩。
She is checking her wound and her uterus contraction.
然后我看一下你下面那个的恶露情况。
She is looking her wound.
看一下她的恶露情况，子宫的收缩情况，然后就量血压。
And she is doing her vital sign and checking her blood pressure.
量血压。
Right, you can check it because the monitor will show how you're checking.
Yeah, you can do the checking the vital sign.
还是就这样量？他要不用电诊器？不用哦。直接会秀，做了好。
You see, Amy seems to very enjoy her checking.
Thank you.
Her breathing is very regular, and then her eyesight is flashing.
好，然后血压量完了，血压多少？105，over68。你的血压正常，伤口看起来没有出血，下面的恶露情况也很正常。要不要我帮你换一下那个看护垫？
She is changing her pad for the wounding.
If you are a tutor during the class, how many score you would like to give this student? 5. 5. The maximum is 10. Maximum is 10. 0 out of 10. How many score do you think that she deserves it? 9.5. 9.5. All right, we'll give her a applause. Thank you so much.
Now these are all the gas connections. And you can see they're all labeled. Air is the yellow hose. If you follow the yellow hose, it's going outside the door. You see it's going all the way out of the door, which is where they have kept the compressor. So there is a compressor outside which has been switched on and which is providing the compressed air. So this is the air hose. Next to that, the blue is the oxygen. Then you have the carbon dioxide, you have the nitrogen, and these are all coming from the tanks that you see, the cylinders that you see just inside the door. Okay, so you can also have in a hospital situation, the pipe gas supply from the hospital can be connected up to this. Only thing that is important to remember is that all connections should be at 50 pounds per square inch. Okay, so these are the gases that go in over here. So this is how the mannequin is connected to the rack. So you have to summarize an electrical connection which you fit, you have right and left lung connections which you fit, and you have two of these fluidic umbilical cables too. There are a number of Ethernet connections there. So one of them can be used for the monitor, instructor monitor. Okay, that is what is connected up over here. Now in addition to that, you will see that there is a SpO2 monitor. Okay, this is the SpO2 monitor, patient SpO2 monitor. Now what happens is this one is only reading from the signal given by this. It is not a real or not, it's a signal generated from the software here and going. But if you want also like a real life SpO2 probe, if you want to use, you have what is known as an oxysim cube. That small blue cube is there with a knob on the top which resembles a finger. Now there is another connection at the back over here which says SpO2. And if you then put the real actual SpO2 probe onto the oxysim, it picks up the pulse oximetry readings just as in a normal patient. So both ways you can do it. Alright, so that is about the SpO2. So when you start up the machine, first thing you need to do is to connect the mannequin to the rack by connecting all these connectors. The next thing you do is to connect the instructor workstation to the rack to the cable. Alright? And then you switch on in the front of the rack, you will find at the bottom at the foot level, if you just so the software can talk to the rack and vice versa. And of course the mannequin is coming to the rack, so everything is together as a package. So is this connection okay?
Just to give you an idea of what we're going to do, okay? We've got these 4 components. And one group will see team working, okay? So if you see something you want to mark, you press the big button, mark what it was, give it a score, then press the big button again, okay? And that resets it for the next scoring. We did have 3 buttons, now that's got 4, okay, so we're doing decision making and we're going to do the other one as well. Give me a second, I just need to go to the telephone and speak to my colleague.
謝謝平和協So prioritising or planning. So I'm asking Mark now to put oxygen on, so you could say, well, okay, I'm planning, I'm predicting what I need to do, so you press that, score it at whatever you wanted to, and then you do it. These guys. Yeah, we've just done it with just leadership on this one, but you can have as many as you want. You can have 5 or 6 different categories on here. Okay, if it was a clinical scenario, you may have, let's say it was anaphylaxis, you could say drugs, ABC, IV cannulation, medications, and you can click on each one of those and score appropriately, and it's being logged.
There is central venous catheter, but it failed, okay? And in the morning, you find the patient unconscious, okay? You are the doctor, you are the nurse in charge for this patient, okay? Your patient lost his consciousness. You should go to see the patient and do what you need to do.
Sir? Sir? I think so wrong. I think I should call doctor. Hello? Dr. Lau?
Hey, hello.
The patient number 1 is Lucas dyspnea and conscious change. Could you see him?
No, I'm busy. Conscious change. What is the GC score?
GCS probably E1, B1, F4.
Probably. Can you tell me actual GCS score?
Wait a minute. Let me see the chart. Anyway, it is not good. The vital sign is not bad.
Please, could you evaluate first?
Okay, wait. The heart rate is around 100, and the resting rate is 30.
Come on. Could you tell me after evaluation? I'm busy.
How dare he came on my core?
So she always tell me what's something wrong, something happened, but I ask something, she always say, I don't know.
Hello, Dr. Lau. I have seen that. The vital sign is not bad, but okay.
So, what is GCS score?
Could you see him, okay?
No, I'm busy.
Still in nurse?
Yeah, still in nurse.
How dare he came on my core again? Sir? No response. Hello, I need help.
What?
What's going on? The vital sign is not good. Vital sign? I told you, ignore my core. It's your problem, not mine.
Not my problem, it's your business, okay?
Hurry up.
Vital sign?
What's the vital sign? Vital sign looks good.
I can't visualize circulation.
Circulation?
What happened?
What happened? And you begging, please.
Okay.
And Bill.
Come on.
What do you need?
Somebody check pulse.
Purse? Oh, the purse is just 40.
40. Okay, I need and you check your tube.
Okay. I'm going on.
Check pulse again.
Pulse?
No pulsation.
Cardio massage.
Hurry.
Come on.
I just have 2 hands. Okay, and down here.
Epinephrine first.
Epinephrine. Okay.
What is blood pressure?
Blood pressure is low.
Come on, epinephrine.
Where I can give the light?
I want intubation.
Here? Intubation?
Yes.
Okay. And down here, I give you.
Do you give the epinephrine?
Yes, I give. I forgot
Okay.
when I give.
Hurry up, please.
Intubating.
So what's the next?
What's the reason of admission?
Here you can see.
Oh my god, I have no time to see.
Come on, somebody help me.
Why? What do you need?
The tube is in. Fix 16.
Okay.
16 centimeters?
Yes.
Is it shallow?
Don't you see this patient is so tall?
I said fix 16, okay?
Okay, are you sure?
Yes, I'm
16.
sure.
Okay, I'm busy.
I'm taking it. Is it okay?
Epinephrine, somebody giving.
I'm
Which
busy.
is asymmetrical.
I am to see it. I don't have a hand, so you can do it by yourself. Don't just shut up.
Hey, the monitor shows
BT, baking, okay?
BT?
It's not like BT.
The patient is dying. Hurry up.
Yes.
What
Why
do you
don't you
want?
ask for actually VT?
So, what should we do?
What do you want to do? Do the cardio motion?
Hurry up.
Okay.
Cardio
Cardio.
Hurry up. Patient is dying.
Okay, this is shot clear.
Charge. Clear.
Does it work?
No, still BT.
Check
What
pulse
else?
again.
What else?
Check
No
pulse again.
pulse.
No pulse. This is shot again.
This shot again. Charge. Clear.
Come on.
Blood pressure is low. What else?
I need epinephrine.
Epinephrine? Okay. I give more one.
Come on, hurry up. The patient is dying.
Come on, epinephrine.
Okay, I give one.
All right. That's the end of the simulation. Okay. Well, I see that you tried very hard to save this patient. Okay, that's good to see it goes that way. Let's think about what's going on, and what we have done, what's good, what can be better next time. Anybody want to say anything?
I called the doctor, but he didn't come before. It's so late.
I think it's not my problem because I can understand the situation because she think and I think it's different. I think maybe it's stable, but as she look, she feel critical, but I don't feel that.
The role, the assignment, that's important for them. Both of them are our residents. But they are equal. But for the nurse, they are equal. Which order should they follow? I don't know that. Okay. So maybe next time someone should come out and say,
How do you do
But I think everybody we enjoy share experience for the meeting. So I think we all work very hard today, and then we have another day for tomorrow. So I just, on behalf of the Fujian Medical School and the Medical College, I welcome all of you, not only participants for the Medi conference, but if you have time, I think you should go to the Taipei. Thank you very much.
I took some time this afternoon to walk around the campus and just to see students, and you can be very proud of them. They're bright, they're eager, they're really full of energy, and I think that's really wonderful. Quite inspiring for us. And so, and I've attended some of the workshops, and I will congratulate you. There's as much energy in this HPSN, and I've had, with that, I'm going to get the heck off the stage. Thank you very, very much. Enjoy yourself.
Thank you. Thank you.
Empire.
谢谢大家，谢谢。Thank you for all. This is about your long scientific community. Thank you for all your attending. Okay. Thank you. Thank you so much. Thank you.
He is now the president of Chang'an Institute of Technology from 2008 until now. His major research interest is very interesting. He is first interest is now on oxidative stress and endothelial dysfunction in aging and sepsis. His second interest of research is gender difference in cardiovascular functions. And above all, I'm most interested in his comment on why female is the better sex in the human society. I would very much interested to find out how he come up to this conclusion after this lecture.
Once upon a time, life for a teacher is relatively easy, okay? Until someone come along and they argue that it's not enough just to know what our students know. Okay, we should know what can they do. Okay, and as far as I'm concerned, that's the beginning of trouble. Okay, because then we need to assess the level of competence. How much can you do? Okay. To assess competence, I guess the students have to have
integrated base on various fields of knowledge. And they have to cultivate ability to solve problems. Okay. Plus, if we're in medical or nursing care business, the students should have the right attitude and characters. Okay. Above all, one also need to have critical thinking and ways to develop, to create new information. Okay. So take it all together, life now is a secret, okay, and we have to decipher it somehow. So today, in the first part of my talk, I will briefly talk about 3 major ways of trying to target this goal. Okay, we're going to do some lecture, some lab, and practice. Apparently, lecturing a large class like this is a very cost-effective way of teaching. Okay, we don't even have to see the instructor here. Okay. Now, in a somewhat smaller class, and if the teacher pays special attention, you will have some form of interaction. Okay, not much, but you can have an interactive class going on. However, there's no comparison to a small group discussion. Okay. I mean, you can see that everybody is happy, and it's very important. It's fun while learning. Okay. Now, it doesn't matter which way. If it's a paper test, okay, the students will develop some friendly competition. Okay, when the exam time comes. Now, there's another form of learning. These are monks from Tibet. Okay, they're discussing about the way, which way is the correct way for Buddhism, and that is to have an open debate. Okay, this will bring students really deep into an issue. Or a case study. Apparently, this professor has a very hard case. Grill on everybody here, and you see nobody smiling. Okay. So talking about a special case that may help the students to focus on the issue and getting in-depth discussion. And then we have PBL. PBL was first developed in McMaster University back in 1991, probably. And it's a pretty good form of learning. It cultivates students' active learning attitude. Okay, self-directed learning. Okay, it's an adult form of learning. I mean, we all learn every day, but we don't go to school for that. Okay, and it's good to cultivate a lifelong learning experience. In 1994, Harvard Medical School published this new pathways. Okay, and after that, it became very popular all over the world. Okay, so PBL is also a form of effective learning. The point is that there are different ways to help the students to dig in deep into an issue. Okay, you want to explore things. You don't want just on the receiving end of taking knowledge from your teacher. However, it's been known for a long time that learning is a self-teaching process. I think it's very important to always remember that nursing is first and foremost a practice discipline. Okay? It's not something you can exist in vacuum. The value of nursing care apparently is in the whole societal health. And recently, we all know, to have good nursing care, we need science-based practice. Okay? We need nursing science. And nursing science comes from practice and also from knowledge structure. Okay? If both together, we can develop adequate nursing science to support nursing care. But after all, we should always remember that the practice side of nursing is the spirit, is the most important thing. Now, apparently, for such a practice discipline, one need ask. And I'll just briefly mention some of my thoughts on how to help the students to develop these competencies. Attitudes. Okay. I mean, the first and the most important is their attitude toward the patient. Okay. And also we know that it's a teamwork, so how they deal with their peers, their colleagues, are as important as how they deal with patients. Okay. And for a teenager to face a patient for the first time, it's quite a shock. Okay. So I think it's important that teachers should spend a lot of time and effort to decrease their level of anxiety. Next, we go on to skills. Okay. Again, we see patient first. Okay. That's consistent with what we call patient-centered medicine. Okay. And then, now this I didn't come up all by myself. This is actually taken from that 1994 Harvard Medical School book, New Pathways. And they didn't come up just because some professor wrote it down. They had the faculty and the students together to discuss what are the values of their education. Okay. They come up with this, basically I add on some things and take away some things for nursing purpose only. So actually, on their list, information, handling information is the second important one in terms of skills. Okay. And then teamwork again. So there are things that simulation or OSCE can do to help, okay, to help the students to develop skills. Okay. Again, patient assessment. Okay. You can see that patients are always on the #1 list. Now, thirdly, the students should have enough fundamental knowledges. And the knowledge, the important part of the knowledge is know their patient. Again, patient should be the first thing on their list.